Welcome to the lecture on the heart. My name is Carlos Andres Suarez-Quian. I am the author and narrator of this lecture. Previously, in the first part of this series, I discussed the mediastinum. Next, I presented the coronary circulation. Presently, I will discuss the heart, in particular, its principal structures and their general functions. On the left panel, I start the lecture by again showing you the heart that Herophilus and Erasistratus dissected back in ancient Alexandria, and their vision for the arrangement of the chambers. 2 atria on top, ventricles on the bottom. On the right, an actual dissection of the heart is demonstrated. Again, you see the 2 atria on top, the 2 ventricles on the bottom. This presentation, however, is not of a heart in the anatomical position. This image of a dissection was produced by slicing the heart obliquely, as is now being demonstrated in the drawing. In reality, in the anatomical position, the chambers of the heart are arranged as across. The right margin is made by the right atrium, the left margin by the left ventricle, the right ventricle is located anteriorly, and the left atrium is posteriorly. Indeed, when the pericardium is first open, the left atrium is not visible because of the arrangement of the 4 chambers. I now move to the right atrium, forming the right margin of the heart, and will describe the structures found there. The drawing on the upper left panel is of an obliquely sliced heart. The blue indicates the location of the right atrium. First, let me label a few structures that should be apparent and help provide orientation. Note the right ventricle, the ascending aorta, the superior vena cava, and the inferior vena cava. The interior wall of the atrium was cut approximately at the surface indicated by the 2 arrows. This incision allowed the wall of the right atrium to be reflected posteriorly. So now we can see the interior aspect of the anterior wall. The space forming the right atrium is now evident, as well as the cavity of the right auricle. Looking at the area where the anterior wall attaches to the right atrium, the crista terminalis is noted. This smooth ridge helps divide the interior of the right atrium into 2 continuous spaces. Anteriorly, the wall of the right atrium is covered by ridges termed the musculi pectinate, so called because they resemble the teeth of a comb. Pecten is Latin for comb. Separating the right atrium from the left atrium is the interatrial septum. Within this septum, there's a depression, the fossa ovale, that represents the embryological opening between the 2 atria, the foramen ovale. The fossa ovale sits just above the opening of the inferior vena cava. One final structure found in the posterior wall of the right atrium is the opening of the coronary sinus, which receives blood from the majority of the cardiac vein. The next heart chamber to be explored is the right ventricle. Again, the drawing is of an obliquely sliced heart, and the blue indicates the location of the right ventricle. In the dissection on the right, note that it is the anterior wall of the right ventricle that has been reflected, opening up the chamber to expose its contents. The outflow tract of the right ventricle, which leads to the pulmonary trunk, is the conus arteriosus, or also called the infundibulum. Note that this area has a smooth wall. Separating the right ventricle from the left ventricle is the interventricular septum, characterized by trabeculae carneae, rich light structures. Do not confuse these with musculi pectinate. They're not one and the same. Entry into the right ventricle is via the tricuspid valve, and the cusp of this valve are now labeled. The cusps of the tricuspid valve are attached to papillary muscles by way of the bands called the chorda tendineae. Oftentimes, three papillary muscles can be discerned: the anterior, the septal, and the posterior papillary muscles. The last structure to point out in the right ventricle is the moderator band. The moderator band forms a bridge between the lower portion of the interventricular septum and the base of the anterior papillary muscle. The moderator band carries a portion of the cardiac conduction system, the right bundle of the atrioventricular bundle, to the anterior wall of the right ventricle. I will describe the conduction system in later slides. The drawing on the upper left panel is of the left atrium. The blue indicates its location. In the anatomical position, the left atrium forms most of the base or the posterior surface of the heart that is now shown on the dissection of the left panel. On the right panel, the wall of the atrium has been opened. Now, on the left panel, a probe has been placed to indicate the location of the superior and inferior vena cava, indicating the right side of the heart. A portion of the right ventricle is just visible. The ascending aorta and the pulmonary trunk are labeled for orientation. Now, focus your attention on the probes inserted into the right pulmonary veins that extend all the way to the left pulmonary veins and exit there. Looking at the open left atrium, the right panel, the posterior wall is now reflected to expose the cavity of the chamber. Again, note the probe in the inferior vena cava and the right and left pulmonary veins. A depression in the interatrial wall represents the valve of the foramen ovale. In some cadavers, the valve can be separated from the interatrial wall. Although the cadaver is from an elderly donor, you must assume that the valve was functionally closed during life. The last chamber to explore is the left ventricle, which forms the left margin of the heart, but also contributes to the anterior and diaphragmatic surfaces of the heart. Note its position in the drawing on the upper left panel. In the dissection, the left ventricle was sliced in a coronal fashion and the two halves separated. Identifying structures with respect to relationships can be difficult at first, but let me label structures that should be familiar to you. The pulmonary trunk and the left auricle should be readily identified. The aorta is also present, but it was cut open and now its cups are evident. The interventricular septum was also sliced, so it appears as two halves. The anterior wall of the ventricle is now reflected to the left side of the image. Looking now inside the ventricle, the anterior and posterior papillary muscles are labeled. Orient yourself to understand why these are labeled as such. Following the papillary superiorly, as in the right ventricle, chorda tendineae attach the papillary muscles to the cusp of the bicuspid valve, only to cusp, or mitral valve, as clinicians often refer to the valve between the left atrium and ventricle. As in the right ventricle, trabeculae carneae are also present in the left ventricle. To appreciate the differences between the right and left ventricles, the anterior walls of the two ventricles were removed and the heart placed in the anatomical position. Let's label structures that are familiar to you: ascending aorta, posterior to the pulmonary trunk, and the auricle of the right atrium. In the atrioventricular sulcus, the right coronary artery is evident, and in what's left of the interventricular sulcus, the anterior interventricular artery and the great cardiac vein are labeled. In the right ventricle, an anterior, posterior, and septal papillary muscle are visible and labeled. Much less clear in this specimen is the moderator band. Moving to the left side of the heart, the interventricular septum is clearer. Based on their relative positions in the left ventricle, the anterior and the posterior papillary muscles are labeled. As shown previously, the papillary muscles are connected to the cusp by the chorda tendineae. Another way to appreciate the differences between the right and left ventricles is to slice the heart close to the axial plane and then examine the slice. This was done, and the heart slice is being shown as one would see the heart in a CT image orientation. Hence, the anterior interventricular artery is to the top of the image, whereas the posterior interventricular artery is towards the bottom of the image. The cavities of the right and the left ventricles are now indicated, as is the interventricular septum. Given the axial section and the fact that the section is presented in a conventional orientation, the anterior and the posterior papillary muscles are easily identified. Now appreciate the differences in thickness in the walls of the right and the left ventricles. Before discussing the sounds the heart makes, let's first simply review the circulation of the blood through the heart and the lungs. Oxygen-poor blood enters the right atrium from the superior and inferior vena cava and from the heart tissue itself. The blood will pass through the tricuspid valve to enter the right ventricle, where it will travel in a circular path to exit via the pulmonary trunk, passing through the pulmonary valve to enter the right and left pulmonary arteries to reach the lungs, where it is oxygenated. Oxygenated rich blood returns to the heart via the pulmonary veins and enters the left atrium, then passes through the bicuspid or mitral valve to reach the left ventricle. Once there, the blood again takes a circular path to exit via the aortic valves to reach the body. The heart then acts as two separate pumps, each consisting of two chambers. Given that the right ventricle only needs to pump blood to the lungs, as you saw in the earlier part of this lecture, its walls are much thinner than those of the left ventricle that is required to pump blood to the whole body. And the heart really functions as a pump. Here's a short video given to me by Dr. Blair Marshall, a former thoracic surgeon here at Georgetown. Note the hiatal hernia she identifies at the end of the movie clip.
You don't see that view of the heart much.
No, and look at this thing. Look, I mean, this is just awesome.
I know.
Fairly
I'm
good.
showing it.
There you go. Perfect right there.
As you probably have heard since you were very young, the heart does make a sound that sounds like a lub-dub, etc. These sounds are made by the closure of the valves present in the heart. After blood passes through the tricuspid and bicuspid valve, that is, passing from the atria to the ventricles, both atrioventricular valves close. This is the first sound, the lub. At this point, ventricular systole begins. The next step is for blood to start exiting the ventricles. At the completion of ventricular systole, the pulmonic and aortic valves close. This is the dub sound. Note, the aortic valve is not shown in this drawing because it is located posterior to the pulmonic valve. Once the pulmonic and aortic valves close, the tricuspid and bicuspid valves open up again and the cycle begins anew. The anatomy of these valves is vital to its function, and anything that goes amiss is likely to be incompatible with life unless the valves are repaired by a thoracic surgeon. We're now at the point in the lecture when we need to discuss how electrical activity is vital for the heart to pump the blood that returns to it, to the lungs, and to the body. Interestingly, heart cells have the ability to contract. They do so embryologically. Indeed, developmental biologists were certain that their stem cells had developed into cardiac cells when they began to spontaneously contract in vitro. Think of these cells as akin to striated muscles. Given that the passage of blood through the heart is highly regulated, the heart cells cannot independently contract willy-nilly, and they are strictly controlled by the conduction system of the heart in an exceptionally precise fashion. Understand that atria cannot be contracting at the same time as the ventricles, because this will lead to a highly inefficient heart pump. After the atria finish contraction, for example, the ventricles begin their contractions. This regulation is brought about by the vitally important conduction system of the heart. Heart contraction begins at the sinoatrial node, that is considered the cardiac pacemaker. Unidirectional fibers carry the impulse of excitation-contraction throughout the right atrium and ultimately reach the atrioventricular node, located within the atrioventricular septum, close to the opening of the coronary sinus. I should mention that all these fibers located within the heart are specialized and insulated from the surrounding myocardium by connective tissue. The wave of excitation contraction also traverses the interatrial wall to reach the left atrium. From the atrioventricular node, a bundle of fibers, often referred to by cardiologists as the bundle of His, leaves the node and enters the interventricular septum. Within the septum, the initial bundle will divide into the right and left bundle branches. The right bundle travels to the apex of the right ventricle and will send branches to the ventricular wall. In addition, the right bundle gives off branches to the moderator band, a muscular beam that attaches to the anterior papillary muscle, which begins to contract to prevent valvular prolapse. The fibers carrying this contraction excitation wave are termed subendocardial branches, commonly referred to as Purkinje fibers. The left bundle branch travels to the apex of the corresponding left ventricle and also gives rise to Purkinje fibers that spread out through the inside of the left ventricle to initiate ventricular contraction. Of importance, the cardiac conduction system can be affected by coronary artery disease. The normal rhythm may be disturbed if the blood supply to the coronary conduction system is disrupted. If a dysrhythmia affects the heart rate or the order in which the chambers contract, heart failure and death may ensue. In addition to regulating the intra-heart contractions, the heart muscle must be able to respond to outside influences. For example, the heart needs to speed up and contract stronger in response to a fight or flight stimulus, as well as contract less frequently and vigorously when at rest and repose. This regulation is brought about by the autonomic control of the heart. On the left side of the image, we see cross sections of the spinal cord and the medulla and a representation of a coronal section of the brain, the central nervous system pathways responsible for the innervation of the heart are discussed in neuroscience, not in gross anatomy. On the right side of the image, a heart is displayed. Let's label the cerebrum of the brain, medulla, and spinal cord sections, as well as the sympathetic chain that forms adjacent to the spinal cord. Also, let's label the sinoatrial node, the atrioventricular node, the aortic arch, and the common carotid arteries with which we are familiar. Efferent fibers from the autonomic system carry impulses to the heart that can either slow down or speed up the heart. Parasympathetic innervation, which slows down the heart, is delivered to the heart by the vagus nerve, cranial nerve 10. This is the stimulus the heart receives when you relax. In contrast, when you need the heart to work vigorously, the heart requires sympathetic stimulation. The impulse to the heart is delivered by way of the cardiac nerve, a branch from the sympathetic chain. As you can see in the drawing, both the vagus and cardiac nerves work at the level of the nodes to modulate heart activity. Although not acting directly at the level of the heart, there is one other cranial nerve that we must mention in this discussion, the glossopharyngeal nerve, cranial nerve 9. This nerve is responsible for regulating the activity of two structures, the carotid sinus and the carotid body. The sinus acts as a baroreceptor, i.e. blood pressure, whereas the carotid body is a chemoreceptor. You learn more about these structures in other courses, but clearly you must realize how blood pressure and blood content will influence heart activity. Given that we just discussed cardiac efferent nerves, or motor fibers, we now briefly mention cardiac afferent nerves, or sensory nerves. After all, how does the heart know to either elicit stimulation to slow itself down or speed itself up? This activity is accomplished by the visceral afferent nerves. Here we see the previous image with all the labels. Now, however, we add visceral afferents that will accompany the vagus nerve back to the central nervous system. In this way, the patient can gain sensation of how the heart is functioning, whether, for example, something is amiss, i.e., a heart attack may be underway. The cardiac nerve is also accompanied by visceral afferents, and these enter the central nervous system at the level of T2 to T4. Visceral afferents associated with the sympathetic system conduct pain sensation from the heart, in particular tissue damaging events, for example, cardiac ischemia. This pain is often referred to the cutaneous region supplied by the same spinal nerves, dermatomes T2 to T4. It is not uncommon for someone suffering a heart attack complaining that their inner arm is also in pain. The patient cannot distinguish the pain arising from the deceased heart from the dermatomes represented in the upper limb. One last image to show the heart is presented here. On the left, the thoracic cavity organs are demonstrated in a dissection. Be prepared to identify the lungs, the mediastinum, and its content. Unless you pursue a surgical field, however, it is unlikely that you will have an opportunity to view many examples of such images. Instead, I suggest you become familiar with a conventional chest film, shown on the right. For your convenience, I now add the location of the chambers in major vessels. You should be able to recognize these in your patients. This now concludes the third and final section on the heart series.